And so in this case, the physician elected to choose treatment with R-CHOP. And I think that was a reasonable treatment. Rituximab probably would not have accomplished what we wanted to accomplish. In this case, we would have wanted to accomplish a relatively rapid cessation of his symptoms related to lymphoma. He was losing weight, he was having fatigue. So probably some form of chemotherapy plus rituximab is, or plus an anti-CD20 drug is the most appropriate line of therapy. Bendamustine rituximab is a reasonable treatment option in a lot of these people. I suspect in this case the physician selected CHOP or an anthracycline because there was some concern for transformation on the basis of weight loss. In any case, rituximab plus CHOP is a treatment that is commonly used in follicular lymphoma and has a long history of activity and tolerability. So it's always a reasonable treatment option. In addition to bendamustine rituximab or rituximab CHOP, now there's data from the gallium study that suggests that obinutuzumab can be substituted for rituximab. So I think that you could argue to use obinutuzumab CHOP or obinutuzumab bendamustine as well in this case. One caveat from the gallium study, I suppose, that requires some consideration is that although this was not a randomized comparison of the chemotherapy arms, the people treated with bendamustine, selected for treatment with bendamustine in the gallium study, seemed to have a higher mortality rate than the people treated with CHOP. This is totally contrary to phase 3 trials comparing bendamustine rituximab to rituximab CHOP. But nonetheless, it gives us some cause for concern that bendamustine may be doing things that we haven't otherwise been aware of. Certainly an immunosuppressive drug and does things to the immune system that maybe we weren't entirely cognizant of. Nonetheless, I think it's still a very reasonable regimen for most people with follicular lymphoma. In this case, R-CHOP was a perfectly reasonable regimen. Maintenance rituximab was demonstrated to be useful in the PRIMA study, which evaluated 2 years of rituximab maintenance after rituximab plus chemotherapy in the frontline setting. That was R-CHOP, R-CVP, and that's where the best data for rituximab maintenance exists right now. Importantly, although rituximab maintenance prolongs progression-free survival, it doesn't seem to have an impact on overall survival. So the goal really has to be, or the consideration really has to be, do the benefits outweigh the risks? So the risks of rituximab maintenance 2 years are relatively modest. Somewhere around 3 to 5% of people receiving 2 years of rituximab maintenance might require intravenous antibiotics for some sort of infection. There's a little bit of a hassle associated with returning to the physician's office. You might assume that patients have more anxiety related to returning to the physician's office that frequently. Studies do not bear that out. Interestingly, they suggest that maybe the opposite is actually true. Patients like the concept of ongoing therapy. And interestingly, in a follow-up study, 10 years of follow-up presented at ASH 2017 by Dr. Salz, roughly 50% of people that were randomized to rituximab maintenance were still in remission 10 years after starting treatment with rituximab chemotherapy. So it clearly is a reasonable strategy to help people experience a maximum treatment-free interval. Nonetheless, it's not to suggest that everybody needs rituximab maintenance. There are a lot of people that don't want to be treated that for a prolonged period of time, who finish chemotherapy and say, I'm done with it. It doesn't impact overall survival, and as I mentioned, it does have some downsides, so it's not something that is in the books for everybody to receive.